Most people with Parkinson's are over the age of 60. You have people under 50, you have people even early as 20s or 30s. And so it changes people's lives to not know what's going on. The idea of having a chronic illness or chronic diagnosis, that's actually not that uncommon. 1 in 5 Americans has a chronic illness. So this idea that we think that everyone else, everything's going on so much better with the Joneses, the grass is always greener, everybody has something going on, whether it's health, whether it's a relationship issues, whether it's financial, people have things going on.
Welcome to the Hope and Help podcast, where we talk about science and science-based tools for fatigue and chronic illness. I'm Haylie Pomroy, #1 New York Times bestselling author and the former assistant director of the integrative medicine program at the Institute for Neuro-Immune Medicine. I say former because that's right, guys. I've decided to go back to school. I am now in the PhD program in neuroimmunology. I'm doing this because I, like you, am a lifelong learner, and there is no better place in the world that does research, clinical medicine, translational medicine, biostatistics, analytics, that is studying how the nervous system and the immune system and inflammatory processes interact together. So that's where I'm going to school. So join me today as we talk about how the nervous system is involved in chronic illness. We have a very special guest. I have Dr. Daniel Kantor. He is with us in Florida. He is the president emeritus of the Florida Society of Neurology, and we have some pretty interesting topics to talk about today. Dr. Kantor, thank you so much for being here with me today.
Thank you so much for having me.
I really appreciate it. And before we started, you and I started just going down all of these, or for me, rabbit holes about the millions of questions that our community wanted to ask you. But first, I want to talk about the immune system and how the nervous system interacts, right? I think so many times we believe that, we can separate the two. So shed some light on this one for me.
So first, I think we have to define some of the things we're talking about.
Perfect.
The first aspect is, in medicine, we use a lot of jargon. Even the word jargon means fancy words. It's a fancy word
for a fancy
that means fancy words. So let's break down what we're talking about.
So you're not going to talk over my head today. Thank you, doctor.
So the immune system, you guys talk about here all the time. But I think it's important not just for me to answer it, but I think when people back home go and see their doctor, I always think it's a good idea if you have a lifetime diagnosis. And I prefer to call chronic illness a lifetime diagnosis.
Like it.
Because it's like the cable station. You turn off the TV, it's still going on in the background. Even when you're not watching it, you still have to pay your cable bills. Right. And so it's the same idea. The idea is that stuff is happening in our bodies and we have to monitor it and we have to take care of it even when we're not having an attack.
Or a flare.
Or a flare. It depends on which diagnosis you have, what people call it. So the immune system is the body's defense forces. Normally, the body fights off outside invaders, bacteria, viruses, fungi. It also fights off your own self when it gets too active, such as cancer. But sometimes the immune system goes haywire.
Yes.
And instead of attacking other things, it attacks you. And we call that autoimmunity. Neurology is the field studying the nervous system, so our nerves. And we think about the nervous system in terms of 3 major areas. The central nervous system, so that's the brain, the optic nerves, which are actually just an outpouching of the brain itself.
Wow.
So it really is true when they say the eyes are the window to the soul. The eyes, why your doctor looks inside your eyes. We actually see the front of your brain.
Wow.
And then there's the cervical spine and the thoracic spinal cord. That's the central nervous system.
Okay.
Peripheral nervous system is from the spinal cord on, so in your arms and your legs. And people probably commonly hear about it when they watch commercials and they see for diabetic neuropathy.
Yeah.
So that's not the central nervous system. That's the peripheral
nervous system.
Then there's also the autonomic nervous system. So the autonomic nervous system is this idea of flight or fright. And for the people listening and watching, I think I don't have to explain too much about how doctors don't often understand the autonomic nervous system as well as they could.
Yeah, or even acknowledge that there's anything impacting it or anything that can better modulate it? I mean, it's this evasive, elusive thing that it's all in your mind, it feels like.
Well, you actually just said something important. You said it's all in your mind. I take care of people with multiple sclerosis or MS. And MS is the most common autoimmune disorder of the central nervous system. We have other ones. It's also considered...
I have to stop you just for a second because you just said something. And I asked you before we started, I'm going to give everybody, we talked before we started and I said, are you aware, because we're so heavily indoctrinated, first in believing the patient, second in believing science, sound science, and third in finding, results. But there are doctors out there. There are people in our community that are having the experience where their doctors still do not believe that MS is an autoimmune disorder or has an autoimmune component. I just wanted you to know that.
Yeah, I got to tell you, it actually surprises me. That surprises me because I feel like it's almost the other way within neurology. Everyone assumes it's autoimmune and maybe part of it isn't. And I usually raise awareness to the fact that part of it is not autoimmune. There's two aspects. There's the autoimmune aspect and there's the big inflammation and the neuroinflammation, and those we call flares or relapses or attacks. And then there's this smoldering idea. There's this low-lying inflammation, but then there's also just breakdown of the cells. Unfortunately, in my field in neurology, we call that neurodegenerative.
Okay.
And I say unfortunately because historically the word neurodegenerative is a very bad slur. It was used in France to refer to the idea that there was degeneration through the generations. So people had a neurodegenerative disorder because there was something wrong with their DNA,
genes. Their genetic code.
They didn't know about
parents.
DNA, but they knew that families.
Oh,
so they came from a
wow.
family where the father had some problems and the grandfather had a little bit of problem. And now the child has many more problems.
Yes.
And so I'm preparing a manuscript actually to send in. I'm considering whether it should go to the field of neurology or something like general medicine, like New England Journal of Medicine or Journal of American Medical Association or Lancet, because I think we should raise awareness to the fact that we're doing that. It's sort of like in medicine, we use words that matter.
There's always such a history.
There is a history.
Yeah,
and,
in nomenclature and in medicine specifically.
I think language is really important. I am a little biased. I was an English major.
Oh no!
I had a concentration in literary theory, and
us dyslexics love you.
So, it's important though how we talk about things. Nowadays we live in a world of gaslighting.
Medical gaslighting.
And we live in a world, not just political gaslighting, not just societal gaslighting, medical gaslighting.
Right. Absolutely. We get patients that come to us all the time that tell us that they weren't believed. Dr. Klimas was saying the other day, we were talking and she said, we wasted 10 years on research just proving that ME, CFS was actually neuroimmunological component or is neuroimmunologically based, maybe infectious based, maybe environmental medicine based. We wasted 10 years. Where in the United States, where in other countries, they were just, yep, it exists. Yep, these are the biomarkers and moving on to treatment and to diagnostics.
And again, a lot of this has to do with the history.
Yeah.
So in the 1800s, they talked about this crazy idea that one day there'll be a doctor that deals with feet and a doctor that deals with the nervous system and a doctor that deals with the stomach. And yeah, we have all these. We have podiatrists, we have a neurologist, we have a gastroenterologist.
And we don't have soloed human beings, siloed human beings.
Exactly. Yeah. And even within our own fields, we become siloed.
Yes.
So even within neurology, I've got to tell you, the neurologists who take care of multiple sclerosis don't nearly talk as much as they should with the neurologists who take care of Parkinson's disease.
Wow.
Or the neurologists who take care of migraine, or the neurologists who take care of concussion. So even within our same field, we don't communicate well enough.
Because in neurology, MS and Parkinson's and those have a common component, or is it because the environment for which they manifest is common?
The reason I think it's important is I think the only way we move forward is by learning from other people.
Right.
And so I think we should learn from other fields. In fact, I actually think that human medicine should learn from veterinary medicine and vice versa.
So, that's my background.
And, no, I didn't actually know that.
So my first degree is in agriculture,
Okay.
soil sciences. I worked with the zoo in Nebraska, Denver Zoo, and then I had gotten into vet school.
Okay.
And then I had to take a medical leave of absence because I was diagnosed with an autoimmune disorder.
Okay.
And after being diagnosed with an autoimmune disorder and being very frustrated with Imurin, Celsep, Mepron, 70 to 80 milligrams of prednisone a day.
Yeah.
I jumped into the world of what was at the time called alternative medicine, which is now called integrative or functional medicine. 30 years later, still practicing in that space, mostly in the nutrition space. But I really feel like we're so further. I mean, I someone the other day said, well, that doesn't relate. It's, human medicine versus veterinary medicine. I said, every single one of your human medicines are used on animal models first. Yeah. So why in the world? Where's the disconnect, people? But
we have a lot of rescue dogs. Yeah. When I want to listen to the heart, I use the same stethoscope. Not the same one I use on patients. I have one that I keep, but the same idea.
Yeah.
And I take care of people with concussion. So in Florida, I chair the subcommittee on concussion for Florida High School Athletic Association.
Oh, wow.
And I was very much involved when we started what I think are the best laws in the country, in the state of Florida. Now we luckily have laws in every single state that the idea is to take kids out with a low threshold. So if you think or suspect they have a concussion, you take them out and only put them back into play after going and seeing a physician and going through the graded return to play. Why do rams hit each other in the head and they don't get concussions? Why do woodpeckers peck at wood over and over and over and not get concussions? Why don't they fall off?
I don't know.
Well, so rams have a area of bone and skull, then they have fat, and then they have another bone.
Oh, wow.
So their skull is made up that way.
So they have a helmet.
They have a helmet, which is interesting because we haven't yet discovered a helmet that's great at preventing concussions.
Yeah.
People sometimes think that's what helmets are for. Helmets are to stop you from having a fracture of your skull.
Right.
And actually what woodpeckers do very, very quickly, so you have to watch on these slow motion cameras, they wrap their tongue around their head. They give themselves a helmet while they're pecking at the wood.
Oh my gosh.
So I think there's a lot we can learn from each other.
We can, and from neurology in general. I mean, from nature, right? That's why I love, one of my favorite journals is Nature. And not just because of the title, but because I think a lot of their dedication to looking outside and looking at what's happening and, showing that a lot's going on in nature that we can still learn from.
It's strange that we even have to talk about this.
I know.
We're human beings. We're of this earth. Like we come from the same soil that those people came from. We come from the same sorts of molecules that make up DNA as the animals, and mostly very similar to the plants as well. And we're all part of one thing, and yet we somehow think it's like an artifice. We think that now I feel like we're talking about Shakespeare. This idea of, are we talking about artifice? Are we talking about what's going on in the real world or not? But the idea is we're part of that world. So for us to think because we're in buildings and we have microphones and we have amazing technologies, that doesn't take us away. That doesn't stop us from taking off our shoes and going to the beach.
Well, see, I'm a diehard nutritionist, right? And I believe in supplementation. And I always say we're the only species that even questions it. Like, you cannot sell dog food legally without supplementing. You cannot have an animal in captivity without supplementing. Like, we don't raise crops. I just go, we cannot separate ourselves. But I think one of the things that's critical that we understand is that we have to look to the history of what's happening in medicine and collect and bring all of that forward, even the history and the nomenclature. And that, I want to talk a little bit about how we're using that both in neurology and in immunology with what we saw with the pandemic and long COVID.
Hi, it's Haylie Pomroy, your host. Did you know that the world's largest single environmental health risk is air pollution? That's right. We are being bombarded by toxins every single day because they are in the very air we breathe. But don't worry, there is hope. Whether you are dealing with fatigue, mast cell activation, an autoimmune disorder, long COVID, viral reactivation, inflammation, anxiety, or depression, all of it can feel overwhelming. I know firsthand what it feels like to fight to find real impactful solutions to your health struggles. I have been where you are. But one thing is crystal clear. We must address the environmental and toxic burden in our bodies. Let me help you do that. Go to HayliePomroy.com/detox and download my free Detox Decoded Masterclass. I will teach you nutrition and natural therapies to help your body eliminate toxins. Let's give you a fighting chance. I cannot wait to see you there.
In our world, in our space, and in our community, I can't believe how many people that I've interviewed that have said, oh yeah, we absolutely saw it coming. We have seen MS have a viral component, right? Mm-hmm. We have seen ME/CFS at times have either an environmental or viral component, some sort of stressor that changed the trajectory in the autonomic nervous system and the innate in the immune system and immune response. How are we seeing some of the history of Parkinson's or MS or ME/CFS play out in neurology in long COVID?
It's an interesting question. Towards the beginning of COVID-19 pandemic, I reached out to JAMA Neurology, so the Journal of American Medical Association. They have a neurology journal. And I was considering writing a viewpoint that neurologists should be front and center in terms of caring for people with COVID.
Right.
And this was before people were talking about the idea of long haul COVID. This was,
Brain
it was a
fog.
Fringe movement of patients, God forbid, that had this idea. And one of them lives right here in South Florida, who's been very, very active. And when somebody has unexplained symptoms, for me personally, and again, I am biased because I'm a neurologist, I actually think neurology is the place to go. Because our job as a neurologist is interesting. We have to look at somebody and we have to say what they're complaining of. Is it neurologic? And if it's neurologic, is it central nervous system, peripheral, autonomic?
But you go to a neurologist and they make you do your fingers and they make you point to your nose and they make you follow a pin and say you look pretty good.
But you see a neurologist because we can find out most things without a test, without an MRI, without a lab test. 70 to 80% of what we do is your history and your examination.
Okay.
I do them very careful. And yes, you'll go to a neurologist, they'll ask you the same question 5 different times because you'll tell them tingling. And they'll say, what do you mean by tingling? And we're asking that for a very specific reason because tingling for some people means what we call pins and needles. For other people, it means no feeling. For other people, it means less feeling. I've had patients who were talking about weakness and they called it tingling. And so, as you can imagine, we have to just be very careful. So language is very, very important in terms of us figuring out what's going on. The neurological examination is long. It's like the Simon Says, lift up your hand, touch your, don't do that. But on the other hand, before there were MRIs, we could what we call localize. We could figure out where something was coming from.
Wow.
And when there is a place that you could localize, it's much easier for people to visualize. And that's why MRIs, for better or worse, are here for better, I think. But the new generation of doctors focus way too much on MRIs.
Right.
And they say, oh, well, this person, I didn't see anything on MRI, so there's nothing wrong with them.
It's like no pathophysiology. It's just anatomically, right?
Exactly.
Is what we're looking at.
And what you're looking at in an MRI is like a still picture.
Right.
In a world of 4 dimensions, and we're thinking like a 2-dimension picture. It doesn't make a lot of sense. But with a careful neurological examination, and that's because of the history, especially in the 1800s, especially with Jean-Marie Charcot in France. And one of his students was somebody you may have heard of, a neurologist. His name is Sigmund Freud. The most famous psychiatrist was actually a neurologist.
It's amazing. But it's right. It's how it should be, right? I mean, that makes sense.
My psychiatric colleagues may not agree with me, but I think one way of dividing it is what happens is we're interested in the nerves, the covering of the nerves called myelin. We're interested in the bulk of the brain and the nervous system. They're interested in the nothingness. So the space in between 2 nerves, the synapse. Yeah. Right, but the synapse is a very small space in between. Yeah. We're interested also in what goes on in actual wires of the central nervous system.
How come viruses have such an impact on the nervous system? Are they housed there? Is it the body's response to it?
Coming back to COVID, what we actually learned from COVID is that in real time, we were watching the creation of new illnesses. One day, thousands of years ago, if you had watched Epstein-Barr, the first time Epstein-Barr virus came, you may have then watched people have multiple sclerosis and put the two things together. But that was so long ago that we can't possibly know about that. But here we have a novel virus where actually in real time, we're seeing people have new neurologic symptoms and other symptoms because of that virus themselves.
Wow. That kind of just blew my mind because I never really thought about the fact that there was such a time lapse in between when Epstein-Barr virus, mono, the virus that causes mono, was discovered and researched to when multiple sclerosis was identified. There was such a difference. And that's because that virus can cause many different diseases. It's not just a straight line to MS, right?
Yeah, about 80% of people have ever been exposed to the kissing disease, to mono. And almost 100%, or some people say 100% of people with multiple sclerosis. So 80% though of the regular population also has been exposed. So the question is, why do some people have one exposure and not get a diagnosis and other people do have that same exposure and do have a diagnosis?
That's boy, are tons of people trying to figure that one out.
Michael J. Fox, who I would argue is America's sweetheart. Michael J. Fox has a disease called Parkinson's disease. Different in many ways from multiple sclerosis. But he said that genetics loads the gun and environment pulls the trigger.
Yes, absolutely.
And I think that is true for many, many of our diagnoses that we take care of. You look at the world of Parkinson, there's a lot of exposures we're learning about. We're learning about pesticides, herbicides. We're learning about Agent Orange, people who work in heavy metals, detergents, solvents. So there's lots of exposures, multiple head traumas.
Yes.
All these things can help contribute to somebody being diagnosed with Parkinson's disease. And then there's also a genetic component. And actually, in things like Parkinson, the genetic component is 10%.
Wow.
And in multiple sclerosis, you take somebody who has MS, guess what? They're identical twin. So exact same DNA. Guess what their chances of having MS are?
What? I have no idea.
It's 30%. So if it was completely genetic, it would be 100%.
Oh,
if it was completely not genetic, it would be 0.1% like the rest of the population, because that's about the prevalence of multiple sclerosis. But it's not. So it's 30%. So there's a lot that has to do with genes, but that's not the only picture. And the problem is we don't think about our exposures well enough. We can't change our genes. I know people are trying to do these things, but we can't really, in a meaningful way, ever escape our genome, I don't think.
But what we do have control over, I shouldn't say that. We don't have a lot of control over our environment.
We don't.
I was just reading the statistic about air pollution, about, how it ranks now as far as disease-causing impacts in our bodies. Like we can't control laws and legislation. Well, we can make an impact. We both smiled on that one. We can make an impact. But if you eat, breathe, drink, sleep, or you're planning on doing that for the rest of your life, you're going to have tons and tons of exposure.
Right? So you are right. There are some things you can't do for many reasons. One of them is socioeconomic. So there was a study done in Southern California. And what they did is they studied people of Hispanic origin, and they studied people who lived next to the highway and people who lived a little further. No difference otherwise in their genetics, no difference overall in how much money they had. The neighborhoods were about the same prices. The people who lived closer to the highway had more MS, had more multiple sclerosis than the people who lived further away.
Wow.
And we have very many reasons to believe that would be true of many, many diagnoses as well. So the things we could do, one of the things we could do, a lot about, is what we put into our mouth.
Yes.
And our food system, the industry here in the United States is problem.
Horrible.
But there are things we could do. I think most people, I don't think they really need gluten. I don't really see why you need to have wheat, barley. I don't know why you need that. I know there's a food pyramid, but that food pyramid is politically based.
Yes,
right? The idea of milk. I don't know why you have to drink cow's milk.
Right.
So
marketing.
Is seafood good? Well, salmon more than tuna, because tuna you have a lot of magnesium exposure. Salmon,
Mercury,
if it's going to be wild salmon, a lot of times, if you're going to have sustainable farming, all that kind of stuff, not salmon with two heads and all that kind of stuff. So there are things that you can do. I know everyone might not love to hear this at home, but alcohol. I don't think alcohol is necessary for human survival.
Right.
People enjoy it. So if you enjoy it in very small moderation.
I want to go back for a second. You said gluten. So again, I've been in the industry for 30 years and gluten became trendy 10 years ago. Let's say, for everybody, I went gluten-free pizza, I went gluten-free this. I was just in Venice, Italy, and they had gluten-free pasta all over the place. But there is, I love this from a neurologist perspective. There is a glycoprotein. There is a problem. One, here comes my ag and soil science piece. We glutenize our product, which means after production, we actually spray it with gluten so that it's more spongy, stretchy, lasts longer, all of that stuff. We hybridize our seeds so that they have a higher gluten content. And gluten as a glycoprotein is, at high levels, it's a neurotoxin, right? It impacts.
And a gut toxin,
right?
Gut toxin. And we know we're learning more and more how important the gut interaction is with the rest of the body.
Right.
Almost every specialty now talks about the microbiome.
Finally.
And probiotics. Yeah, finally.
I have a video a class that I was teaching. I was pregnant with my son who's 26, and I was talking about the gut microbiome, and I just laughed because I'm like, I was banging down the doors, 27 years ago now. But I'm so happy to see that shift and change.
But we still haven't changed our food sources.
No, I was just going to say that.
You mentioned Europe. When I travel to Europe,
I don't have a reaction.
I can eat croissants.
Right.
I don't need gluten-free foods. It's very interesting because when I'm here, I will be sleeping the rest of the day if I have gluten. But there, I don't. But there's something very, very different about
we utilize glycophosphates in our, we spray, right? We spray very different products. Yep. And you're going to get in my agriculture.
We have Roundup. Our neighborhoods, here we live in Florida, we have homeowners associations. They're spraying tons and tons of these things. When I first moved into my neighborhood, everyone's dog was getting sick and vomiting because there were, dogs eat grass or they lick things on the ground and they were getting poisoned.
Yeah.
If it affects them, don't we think it affects us?
Yeah. Oh, no. Or the kids in the school.
Well, I can tell you, my daughter was actually
one of the sickest buildings. Yeah.
My daughter is now 9 years old. So several years ago, she was actually, they were play fighting with her older cousin, and in the grass, right in front of our house, she got periorbital cellulitis. She's lucky she didn't lose her vision, but it was a hospitalization, IV antibiotics, all these kinds of things that. Thankfully, we have modern medicine easily accessible in the United States for most people.
But why?
Why? So
I'm just saying that.
So you wonder, she got microabrasions probably by wrestling. Is the fact that the grass was soaked in Roundup, did that have any effect? Is that how the bacteria got into the area around her eyes? It's possible. We don't know exactly what happened. She didn't have a gash. She didn't have anything visibly wrong with her, but her eyes started swelling. At first, we thought it was an allergic reaction, but then we realized what was going on.
Hey, folks, it's Nancy Klimas. Thanks for listening to the podcast series. We have a lot going on and a lot of research going on in ME/CFS, in Gulf War illness, in long COVID, Parkinson's disease. You'll find that we have a number of trials going on, clinical trials and different types of studies. To learn more, just go to our webpage on the research tab at nova.edu/NIM, Neuro-Immune Medicine, and you'll see everything that's going on right now. We even have patient conferences every year. We have one coming right up. So check out our webpage. Thanks.
Okay, I'm gonna pull you back for a second to two things. One, because it's just fascinating to me. When we saw COVID coming, when COVID became in our reality, a novel virus, did we think that did you guys think that there was going to be this short line between, we're seeing people, with autoimmune triggers, we're seeing people with all kinds of neurological impacts, with individuals with inflammatory impacts. When I was over in Europe, they were talking about, they're, talking about Asia syndrome with the adjuvants. Did we think that this in general was going to trigger disease so fast? Or were we thinking with Gulf War injury, we would see people coming back and 6, 5, 7, 10 years later, they were manifesting symptoms?
It's very easy now to say, oh, we knew about it. We had no idea.
Okay.
Firstly, in medicine, we don't know most things. We have an idea of very few things. We have agreement on some things, and we do the best we can. I wish actually that that's the way medicine had approached this idea of COVID. Instead of making it a political pandemic, we should have gone up there. You should have had
we don't know what the hell we're doing.
The House of Medicine saying, we don't know, but let's do the best we can.
Yes.
I got to tell you, a lot more people would have masked if you had been honest with them.
Right.
If people had come and said, we don't know what to do, but a mask costs 50 cents to buy, so let's just do that. We might be wrong, but let's just do it and let's all agree to do it together kind of thing. Instead, we had government officials telling us one day to wear no masks, the other day to wear 2 masks, 1 mask, 3 masks. It was very confusing.
And I think the hard part was where we lost the field of science was we were so adamant that one person was right and one person was wrong, no matter which aspect or which side. There shouldn't be a side in science, period. There should be pondering,
I actually just wrote a letter
and then
to the
research
editor.
again, and then more research, yeah.
I wrote a letter to JAMA talking about how doctors should not follow dogma, because medicine is not about dogma. That's why it's always amazing to me when we talk about complementary and alternative medicine. Medicine, allopathic and osteopathic medicine, so MD and DO, what most people call doctors in the United States, we are the most holistic. I don't care what the mechanism of how acupuncture works. All I know is I've done pretty good studies and it works for some people with migraine.
Right.
That's what's important to me.
Right.
Actually,
And
is
what are
it
the side
chi
effects?
or is it not chi?
What are the side effects?
Hippocrates taught us, first do no harm. That's our thing, first do no harm. So while it is invasive because you're sticking a needle, you're sticking a very small needle and very, very shallow.
I had a doc the other day that a client walked out and they said, my doctor said to avoid, I don't know, it was some food, like, I understand grapefruit with cholesterol medication, but it was like avoid this food and this food, all, natural foods. And I said, did they say anything about the Popeyes chicken, anything about, the KFC, anything about the McDonald's, anything about the Coca-Cola? No, they just read somewhere that some food is bad for you. And they jumped on that band, like keto, don't even get me started. All of those types of things where we start to do that. A lot of our community, and this is why, and even in my PhD work right now in neuroimmunology, a lot of people in our community have never felt like or feel like or misunderstand that the immune system is not involved with the brain. How can you help me communicate effectively how those work together, or if they're one and the same?
So there's lots of different systems, and even that, the idea that we split the body into systems is artificial, right?
Yeah.
I mean, it's just an easier way for us to understand it. There's a lot of crosstalk, and that's what we call it. And I think that's actually a useful term. And you've interviewed here and you've talked on this podcast about mast cells.
Yes.
And so mast cells actually communicate very well with certain types of other cells. One of those cells they communicate with is neurons.
Oh, okay.
So sometimes you have a chemical messenger that happens locally. And those we call cytokines and chemokines. And you heard about cytokine storm, you may have heard of, having to do with COVID and all that. Then you have sometimes a chemical that happens in one place and travels through the body and has an effect somewhere else.
Right.
That we call hormones.
Yeah, this is just going to say hormones, yes.
And so in the immune system, what we have is we have that traveling, but that traveling is going through a system of T cells, B cells, natural killer cells, and other regulatory types of cells. And then the nervous system connects it with actual wires, right? So there's actually a substance that actually connects them. It's not that it's traveling through its substance.
Time and space.
It's a wire, and then there's a space, and then there's another wire.
So it's different than like traveling through the bloodstream?
Exactly. It's different than traveling through the bloodstream, because you already have to, if it's in the central nervous system, so the brain or spinal cord, then it has to get through that blood-brain barrier. There's a barrier that's made, and we have it to stop outside things from getting into our brain. Right. And it used to be, years ago, we thought the immune system did not happen inside the brain. Right. We thought that it was sanctuary.
Yes.
Now we know that's completely wrong. 7 years ago, we didn't know there was a lymphatic system in the brain.
Yes.
Which is amazing to me. We're still making discoveries in like the 2000s of things that we didn't know. Now we call it the lymphatic system. Like we have a whole system. We have people who specialize in it. It's amazing the advances that are still happening. But at the same time that advances happen and at the same time that research happens, we have to remember the job of clinicians is really to have that doctor-patient relationship.
Right.
And I think doctors need to hear that more now than ever before.
Yeah.
Artificial intelligence already passes all the medical tests. Computers are going to be able to know more individual genes and questions that are on the board examination than doctors. So the only advantage doctors have right now should be that relationship. Except there was just a paper that came out that people with multiple sclerosis preferred the bedside manner of artificial intelligence over their doctors. When I saw that, it's all come tumbling down.
But do you think that's because there's no judgment?
There's no judgment.
There's no gaslighting.
There's no gaslighting. There's no rushing. There's no triple booking. There's a lot of things.
Wow. So when I was in Slovenia this last couple of weeks at that International Autoimmunity Conference, we did a whole section on AI. Mm-hmm. And they were putting in clinical notes and, patient, and these people were spitting out diagnosis that people said took 5, 6, 10, 12 visits. And to your point, it can pass all the medical exams. All of that data can be processed. The only thing left is the relationship. And to me, in medicine in the United States, the thing that's missing most is relationship. I mean, so many people don't have a connection with their doctor. It's hard. It's like speed dating, but worse.
And here, as opposed to the food, I actually don't think America is behind Europe, for example. If you have MS in Italy, you have to stand while you're there with the doctor. They do that so that you leave the office visit pretty quickly.
Faster.
You can't have more than a 7-minute visit and be standing.
Right.
And so it's a problem of medicine in general.
Globally.
Medicine has forgotten what our roots are. So our roots are the word docere, which is Latin for instruct or teach. The job of a doctor is to be a health coach.
Wow.
Yet we have a whole other field of health coaching.
We certify health coaches.
Our job is to use our expertise and to give you advice based on it. It used to be paternalistic, like what we said had to go. The world's not like that anymore.
No.
So all we can do is...
I want to say that though, because so many people in our community still feel like, we had someone that said, I just got fired from my doctor because he wanted me to take a particular medication. I wanted to talk more about it or ask him if I could have 45 days to see if I could reduce it on my own. And he genuinely told them, if you don't take this medication, you can't be my patient. We had that happen.
The doctor did them a favor.
Thank you.
Because that's not the kind of relationship. I always talk about this when I talk to groups of people with a diagnosis is, sometimes there probably would be good if that doctor-patient relationship, if there was an outside person like a counselor, but people don't even do that for marriage. They're definitely not. If you're at a point where you're talking about doing that with your doctor, then you need to find another doctor.
So we certify health coaches, nutrition-based health coaches. And one of the biggest things that we're coaching them on nutrition. Over the years, the evolution of what clients that come through the door need is preparing them to how to engage with their practitioner, how to beg for labs, or I'm going to use a nicer word, how to get adequate diagnostics, right? And how to prepare them for that so that they can have success with their practitioner, their physician, their practitioner relationship, right? Because otherwise, if we don't have that, if we can't create the bridge, right, to get across that chasm for that relationship, it's really hard for us to intervene with a nutritional approach when we don't have a partnership in running diagnostics. If a person goes in and their cholesterol's high and they say, whoa, okay, this is my wake-up call, right? I want to change my lifestyle. I want to look at my potential risk factors, maybe smoking, maybe drinking, maybe, the environment which they're eating, what they're eating, the environment where they're getting their foods. I want to look at because we do risk assessment. I want to look at all this. I want to make an intervention and see if I can't metabolize, because metabolizing cholesterol is a normal function that we do all day, every day.
The brain is made up of fat.
Really important from a neurology perspective.
We really need cholesterol.
Yeah, so a lot of my neurologist friends don't love it when a cardiologist drives the cholesterol down without any modification in lifestyle, right? But sometimes we have to just bridge the gap or help them create. We have a form that it's called a request for care, how to communicate with your doctor when you come in and have a good, positive relationship and all of that. We work really, really hard on that. But we have to create an industry of health coaches so that people can have advocacy to get diagnostics at their doctors. That's crazy.
And you know what? AI could replace it like that.
In a blink. Absolutely. It is. Yeah. We use AI all the time. Absolutely. Interesting.
But I want to come back to your question was about COVID-19.
Yes.
And could we look at it and know that this was going to happen? No. Did we have any idea? No. Were we all spraying our Amazon packages? Yes. Was I stuck in my house and we didn't even see our sister-in-law and our nephews for like 6 months? Yes. Did we realize at a certain point that was silly? Yes. And so...
But if you drive across America, because I was from LA, the Dakotas, it was so... I'm just telling you, I went to Utah in the thick of it. Took my parents to the ranch in Colorado. Where I was in Utah, there was not a single human being that was experiencing COVID. I mean, I'm not saying they weren't having the disease. I'm saying psychologically, socially.
Yes.
It was as if it didn't occur. I thought I had, remember the Twilight Zone?
But now you understand why so many people moved to the wonderful state of Florida during COVID. I mean, we saw huge influx of people from New York and California.
Right.
And there's good reason for that. We kept our industries open.
Right.
We made sure.
You made monoclonal antibodies accessible.
We made and frankly, we made vaccines available too for people who wanted to start a new vaccine. At the same time that doctors got them, seniors were eligible for them as well. And then we just went down the line to other people. We start getting to children. That's where I definitely say stop, because I'm not sure why you would vaccinate a child against a disease that doesn't affect children as much. It just doesn't make sense to me.
Right.
And actually, talking about vaccine, I know maybe this is a topic that I should be careful talking about.
When I was in Europe, they talked about it so freely. I got like sweaty. I was like, what? I was like looking left, looking right, going, is it okay that, I mean, all these genius scientists were all in a room talking about it. Just like we should talk about this. They're talking about the adjuvant, and, certain countries had mercurous salts in them. Certain had aluminum in them. Yeah. And they were just talking about it. And I was like, I was going, I don't want somebody to think I have any, opinion. That's what we're supposed to have as scientists.
But this is not only that, that's what we're supposed to have in the United States of America. Yeah. We are a constitutional republic. Our First Amendment is freedom of speech. And yet people aren't allowed to talk. And that's crazy, because that's not how science and medicine is.
I know.
I gotta tell you, before COVID, I would go to conferences. Somebody would be presenting data on a new medication. I raised my hand. I said, why are you being so laissez-faire about risk of cancer with this drug? The guy's a colleague of mine. He's a friend. Yeah. But I'm going to call him out.
Yeah. Well, that's
okay. We could continue our relationship beyond that.
We were sitting at a table with a doctor from St. Petersburg, a doctor from Germany, a doctor from Italy, and they were just having this banter back and forth. And I was kind of I was dripping sweat as an American scientist, female scientist, going, is it okay that we talk about this? Which is so strange. I'm going to drop this one. It was like, for me, the ivermectin conversation. I had for years worked with many doctors in CIPD, and they were using Stromectol in their patients for 25 years. And I also have cattle and horses. So it broke my heart, because these were brilliant doctors that had used, and we use it neurologic. I'm not, so everybody doesn't get up in arms over me. I'm just having a conversation. I just was heartbroken that people couldn't.
When they call it a horse drug?
Yeah, that everybody says they're over there buying horsewormer. And I was like, I have a client that has used Stromectol in CIPD with gamma globulin infusions successfully as part of her neurologist prescription that she picked up at Walmart for 25 years. Mm-hmm. And I was just like, oh no, it just bummed me out. All of it bummed me out. I guess all of it bummed a lot of people out. But I appreciate being able to have this conversation and talk freely. I look left, I look right.
I mentioned that I wrote a letter to the editor to JAMA. The reason for it was a paper that was about inoculation against misinformation. So the authors used as an example, their terminology was about the very thing that people are upset about.
Oh, no. It wasn't by accident.
No, but they're talking about inoculation. Like, they're proving the point.
I know.
And what they're doing is they're taking mainstream people. Before COVID happened, mainstream America was about getting polio vaccine, measles, mumps, rubella. It was most people did that. Then COVID comes around, and I got to tell you, even people who have given vaccines were like, oh, wait a second. Why are all my friends having tinnitus? Why are they having ringing in their ears?
Yeah.
Why are their symptoms getting worse from a vaccine? Yes, it can be helpful for some people, but not for other people. And if we can't talk about that,
we
then
have
we've got
to talk about it. And why can't we talk about it? I'm with you. The thing for me, I mean, I am of the belief system personally that everybody should have, a choice. Everybody should have data, and everybody should have information. I mean, but we had we had a family member that had a documented vaccine injury and lost his life. And at a very amazing hospital. And they were lovely to us. And the doctors and the neurologists, because he had a cerebral bleed 4 days post technically, but 2 days post. And they were able to look at titers and the CK, all of the diagnostics they did. And they were data collecting too. They asked us, to release a lot of information. And they were so awesome about the conversations that we were able to have with them, and so kind of free behind closed doors. But they were like, but just so you know, we can't go out and, I mean, it's documented, it's written up, it's fine. Yeah. As far as, and then it was so strange. I was flying home and I was sitting next to a gentleman that had, a massive neurological response post. And I just went, I see it, and we can't talk about it. And it's not to vilify anything, but it's just because when we sequester knowledge, we sequester results, period. Right? And so, I don't know.
And we don't live in a world where you can sequester knowledge. Knowledge is freely available on the internet. It's out there.
It's too late, guys.
It's too late. There's no
and with
secret.
AI, it's too late.
There's no secret knowledge that's out there. It's just a question of some people are accountants. Some people are school teachers. Some people are doctors. It doesn't mean that the doctor can't figure out how to fix their car or that the mechanic can't figure out how to help their illness.
Right.
It's just not what they specialize in. The doctor is seeing a lot of people. And so they should be able to look at you and say, you know what? You remind me of 5 other people I've seen. I'm not sure you're going to respond the same way, but from my experience, this is what I believe.
My name is Jimmy Orocho. I am a veteran of the 1990-1991 Persian Gulf War, Desert Shield, Desert Storm. I work for Dr. Nancy Klimas at the Institute for Neuro-Immune Medicine in Nova Southeastern University. We are in Davie, Florida. We are Gulf War illness clinical researchers in the need for research participants. By participating, you will help yourself and your fellow veterans, contributing to the discovery of the cause of Gulf War illness and how to best treat the illness. Our telephone number, 954-262-2870. Our email, QuickTick, Golf Whiskey India Charlie Tango India Charlie @nova.edu. We do also decentralized clinical trials. That means that you may be able to participate in this research from your hometown. Thank you very much.
So I have 2 questions. One, I want to talk a little bit about Gateway, right? Yes. But I also want to talk about patients. Sometimes, and I love case studies, but sometimes you've talked about, scary aspects of their diagnoses or some cases that you've seen. Can you just share a little bit of that with us?
For example, in the fields I take care of, so I mostly take care of people with multiple sclerosis, with Parkinson's disease, with concussion, and with migraine and other headaches. Looking across
and
all
here in
of
Florida.
those, and here in Florida, and looking across all of them, the most disabling issue is not weakness. The most disabling issue is not a wheelchair. The most disabling issue is uncertainty. People want to live their life, and people have a vision of their life. Some people, so much so, when they're like little girls, they start dressing up in wedding dresses, right? So they have a vision of what's going to happen.
Or have a million ponies.
Right. So people have a vision of what's going on in their life. When you get diagnosed in your 20s to 40s with a diagnosis, you don't know what that means. You hear the worst, or you look on the internet, or the most famous doctor is Dr. Google. You go there, you think about things like Parkinson's. So most people with Parkinson's are over the age of 60. You have people, under 50. You have people even early as 20s or 30s. And so it changes people's lives to not know what's going on. The idea of having a chronic illness or chronic diagnosis, that's actually not that uncommon. 1 in 5 Americans has a chronic illness. So this idea that we think that everyone else, everything's going on so much better with the Joneses, the grass is always greener. Everybody has something going on, whether it's health, whether it's a relationship issues, whether it's financial. People have things going on.
We're hoping to give them, to spread hope that there is a shift and a change and progression in science and ideas. But I will tell you, having an autoimmune disorder myself and talking to a lot of people in our community, there is that fear of the flare, right? Or when is the next shoe going to drop? because my autoimmune is ITP, I have had a hematologist for years. We're now buddies, right? And I've been able to get off of all anti-rejection drugs, no steroids, none of that stuff. I'm able to treat with lifestyle medicine. All different aspects of natural therapies for myself personally. Feel amazing. Labs are amazing. But there's, something will happen. Like I flew and this woman had tons of perfume on and I started to get my blush. I call it blush and eyeshadow. I get blush and eyeshadow. And I went, oh no, oh my gosh, what's going to happen? That uncertainty, are my gums going to bleed? Am I going to start bruising? All of these things that even after having a lot of successful health episodes, right? There's still that uncertainty, that fear of the flare. So much so that my hematologist that I've known for years had asked me, and I speak on behalf of a lot of different organizations, and it asked me to come talk to a group with individuals at ITP. And it was the first time I said no. Yeah. Isn't that terrible? Because I thought to myself, not that it's contagious, but I thought to myself in my mind, I can't associate it with it anymore, which is I'm working on. That's my next work, that it's my own personal journey that I've started, because I thought after all these years and all this health victory, that still wasn't there. But obviously it is. I said no, and I had to look at why. And my goal is to always get to a yes when it's
support groups are for some people and they're not for other people.
Right. But to talk to them about what I did and how I made changes and what kind of changes you can do from food and lifestyle modification and, the different, I've been all over internationally for different types of therapies for myself, some biologics, some others. But I just went, whoa, I still have that fear. You know what I mean?
Yeah.
That somehow,
and fear is a strange thing, right?
So and I'm not afraid of much. I'm not afraid of much.
Fear made sense when there was a lion that was about to eat you.
Right.
It makes sense that you go into this flight or fright idea. Most things that people are scared of nowadays aren't going to kill you.
Right.
When you go and give a speech in front of other people, you're not going to die. But yet our mind tricks our body into having those exact same fears. It makes no sense.
Same emotionality too.
It's the same.
I two things. Please promise me you'll come back. I feel like there's 10 topics. So every time we run, especially an amazing podcast like this, our community asks us more questions. Our goal was to give people access to individuals like you because they don't have access. So first, promise me you'll come back.
I promise.
Okay, thank you. In the meantime, you have created this AI interactive program where individuals can ask Dr. Kantor, right? And it takes all of the lectures and the videos that you've done, and it tells you exactly where in the lecture, and it gives an answer, correct? Where do they go to for that?
Yeah. So over the past 2 decades, what I've done is filmed more than a few thousand videos, mostly about multiple sclerosis. And so the team at We Health, they powered an artificial intelligence bot that basically you can either read it a question, or you can speak it, or you can type it out, and it will give you an answer based on the videos that I've interviewed other doctors on.
I love that.
And it will actually then give you the portion of those videos so you can actually go back and watch them. It's better than a keyword search. It's better than any kind of search that would have been imaginable a couple of years ago. Now you can actually freely ask it. We have it now for MS. We're going to build it for Parkinson's disease as we build more and more videos. And then we're coming for the next one.
And they go to GIFBR.com.
So GIFBR.com is Gateway's website.
Okay.
To go and ask Dr. Kantor.
Okay.
It's actually an easy thing for people to remember.
Okay.
It's bit.ly, so bit.ly/ask Dr. Kantor. So ASKDRKANTOR.
Perfect. I just want you to tell me, I know that you are part of Gateway. Can you give me some information about Gateway?
Absolutely. So Gateway Institute for Brain Research is a mission-based brain research institute located right here. We actually lease space from Nova Southeastern University. And so we're in the same building. We're in the same building as INM. And we have a simple mission in some ways. It's to cure, not to treat, not to help a little bit, but to cure Parkinson's disease.
I love it.
It's a very straightforward mission, a mission that I think we can actually accomplish. And I'm the vice president of clinical research and development for Gateway. And so Gateway is structured in some ways, because of Dr. Klimas, in some similar ways to INM, where we have, and I know that you've interviewed Travis, for example, so we have a lot of what we call in silico. So meaning we first start with computers in some things. So we do computer modeling, mathematical. We have mathematicians and physicists, and we're doing those kinds of models. Then we have the people in the actual lab. So think about Petri dishes. And then you have people who are actually doing research, unfortunately, on rodents, so on actual animals.
Right.
And then when something's finally ready to reach human beings, that's when we step in. I've been a clinician for 20 years, but the reason I decided to focus a lot of my time, not just on doing research trials, but on really being involved with an institute like Gateway, is because of the opportunity to actually make a difference.
Right.
Our founder, instead of us wasting time, frankly, wasting time, applying for federal grants and other grants and to keep salaries going, and you do a grant cycle every 5 years and you keep going, he doesn't want us wasting any of that time. Instead, he wants us just doing the research and he'll cut a check for it, which is amazing. Because that's the only way we're going to have a model where we can cure diseases. And once we cure Parkinson's, we're coming for the next disease. Right. So we're not going to stop there. Right. We're going to keep on going. And it's amazing what we can do when we come together. So you have people who are mathematicians and computational biologists, talking to people who are clinicians, talking to people who are laboratory people, either with mice or with Petri dishes. And together we can all do that. We have an annual meeting, an internal annual meeting. The company's about 34 people, 35 people. And this year I taught a little mini course on some of the clinical aspects of Parkinson. Because I realized people in the lab, they may have a family member with Parkinson, but they may not know about that kind of stuff. And next year, what I hope to do is actually bring in a person with Parkinson's disease and have maybe a fireside chat. Because it's strange for me that we're actually having this conversation this way. I'm used to actually being the interviewer, not the interviewee. And so if we just had that kind of conversation freely and openly in front of people, then people who aren't seeing these patients on a daily basis can understand what they're going through and why they should stay up late at night and finish the job that they're trying to do.
That's what I was just going to say. I think sometimes, and which I love that we really stress this, sometimes there's such a separation between what you're doing in research and the human being that you're impacting.
It's really interesting.
We wouldn't push a lot of drugs through that have so many side effects if that were the case, in my opinion.
When I went to college, at University of Pennsylvania, I obtained a Bachelor of Arts in English Literary Theory, but I also obtained a Bachelor of Science Engineering in Computer Science Engineering. And I remember in medical school, I turned to somebody else and I said, "When's the last time you stayed awake all night, not because you were cramming for a test, but because you wanted to figure out a problem?"
Right.
They looked at me like I was strange. They said, "Why would you stay up to figure out a problem?" And I got to tell you, we would do that in engineering. We drank our Mountain Dew.
Absolutely.
We stayed awake, and it wasn't due tomorrow, but we wanted to solve that problem. There's a lot that the field of medicine can learn from the field of engineering as well.
Absolutely.
And here we were passionate just about building computer systems.
Solving a problem. Absolutely.
Imagine how interesting and imagine how dedicated people can be when they actually have the ability to change people's lives. Parkinson's disease is the second most common, what's unfortunately called neurodegenerative disorder. First Alzheimer's and then Parkinson's. Wow. It's very, very common. Everybody either has it
and there's
or has
no
a family
cure.
member, and there's no cure.
And there's not even
disease-modifying treatment.
Right, I was just going to say, there's not even disease-modifying
treatment. In MS, we have 20 plus disease-modifying agents. Depends how you count them. In Parkinson's, we have 0.
Wow.
We have medicines to basically replace dopamine. They're basically symptomatic medications that people have to take. They have some surgery, deep brain stimulation, which also doesn't cure it. It can control a lot of the symptoms, not all the symptoms, but you're not modifying. You're not doing something to change the course of disease like we have in rheumatology,
right, with
rheumatoid arthritis or psoriatic arthritis,
right,
or with multiple sclerosis. I actually went to the conference. The Parkinson conference was down here in Miami 2 years ago. And when I walked in, some of the people recognized me that I'd been a long time in the world of MS. And they said, "Oh, why are you here, Dr. Kantor? Because you guys already solved your disease that you take care of." Because it's palpable. I got to tell you, in the conferences nowadays, you can feel in the air, like we're ready. The field of Parkinson's disease is ready for something that can modify.
Yes, and we have to. And I'm it's exciting to see, and I definitely believe that the founders' unwavering commitment to finding a cure has moved your guys' research forward so quickly.
Absolutely.
Yeah, absolutely. Our community is going to love that resource. Thank you so much for coming. I have 10 more questions, but we're going to be out of time, but you're coming back. You've already promised. And you guys, if you have questions for Dr. Kantor, please make sure you post your questions below here. I will go through them, I will sort them, and I will ask them on your behalf. I cannot thank you enough. It has been such an enlightening conversation. I can't wait to rewatch the podcast myself because I feel, you'll see, I've taken tons of notes, but it was a very significant learning experience for me, and I know is going to be a huge resource to give people more hope and give them tidbits of help, right? So that they can help.
Because no hope is false hope. A patient taught me that there's no such thing as false hope. Every hope is good.
Every hope is good.
It's not having hope that's the problem.
That's not having hope. That's why we're here. That's why we're doing this. And that's why we have amazing people like you here with us. So thank you so much.
Thank you.